Well, hey, everybody, this is Robert, and welcome to today's show. Cholera, it's been a major public health concern in many parts of the world for a long time. We see large numbers today in Africa and parts of South Asia. In the past decade, we've seen massive outbreaks in Haiti and Yemen. Um, so, we're going to take a closer look at what's going on with cholera, what is it, and the situation globally in 2023. And joining me today to talk about this is Peter Gilligan, PhD. Dr. Gilligan is the former director of the Clinical Microbiology-Immunology Labs at the University of North Carolina Hospitals. In addition, Dr. Gilligan recently authored an article on ASM.org about this topic specifically, and I'll feature it later in the show. Dr. Gilligan, welcome to the program, my friend.
Hey, Robert, thanks so much for having me, and welcome to all the people listening to this as well. It's good to be with you.
Good. I really appreciate you coming on. Your article was very good, and we've been trying to work this out for a month or so, and we finally got to do it. And I think the audience will appreciate what you have to say. Can we go ahead and start with a little bit about the history of cholera?
Sure.
Yeah.
You want me to talk about it, or are you going to talk about it?
You're on. You're on.
Okay, I'm on. So, cholera was actually recognized as a disease in humans before we knew what really that microbes caused disease. Isn't that interesting? And John Snow is sort of a key player in our understanding of the epidemiology of cholera. He did studies in the mid 19th century, again, before we really appreciated the germ theory of where he showed that there was a major outbreak in an area of London, and that outbreak, using a mapping where the cases were, was associated with a particular pump. Now, way people got water in the poor people, well, I shouldn't say the poor people, but the people who lived in a more sort of more modest circumstances, got their water from pumps on the street. What he did when there was a particular outbreak, and excuse me, I don't remember the exact year. It's in the article, though, so if you read the article, you can see the year if you'd like to know that kind of information. And essentially what he did was he mapped the cases, and there was a workhouse right nearby where probably the outbreak first started. And what he found was that there was a particular pump where people came to get their water, and they lived close to that pump. And so he could show that the cases came from all around the area of that pump. And that pump was called the Broad Street pump. So it's very famous in microbiology. And one of the things that he did was to stop, I don't know if he stopped the outbreak, but certainly reduced the outbreak, was to actually take the pump handle off the Broad Street pump, so people couldn't get water from there anymore, and the number of cases declined from there. That pump is still there in a square in London, and I've actually been there. I guess I'm a real microbiology nerd from that point of view. One of the things that was interesting about this, though, that sort of sealed the deal for, I think, a lot of people, was there were some cases out in the country of cholera, which have nothing to do with the Broad Street pump, but it was subsequently learned is that family members who lived out in the country, actually family members who lived by the Broad Street pump, actually brought them water from that pump that they then drank and got the disease. The way you get cholera is to drink water that's contaminated with this organism. The organism actually is an aquatic organism. We find it in water. It survives, it multiplies, it divides. And Vibrio cholera in particular prefers to grow in halophilic environments. So that would be in brackish water and in seawater. But it can also obviously grow in fresh water because of the outbreak that occurred in London. And the way the water, well, how the organism gets in that water when you have an outbreak is people with cholera um, excrete it in their feces, and those feces contaminate the water. And there's very nice studies to show that cesspools actually from homes that where people had cholera actually leaked into water from those cesspools into the Broad Street pump aquifer, I guess you would call it. So that's what we know about the history, brief history of it, the early understanding about cholera. And later on, folks uh, working, I think Emile Rouleau and Louis Roux actually worked with Robert Koch in Cairo to actually find the organism in the water there during a cholera outbreak. Once we knew there was, microorganisms cause disease, and this was, I think, in the 1880s.
Yeah, and the just for anybody's interest, the outbreak on Broad Street that Dr. Gilligan's talk about was 1854.
There you go.
Yeah,
I'm
got it from
glad.
the article.
I'm glad you're here, Robert. Otherwise, I would be in trouble.
Yeah, I got the article at my fingertips.
Okay, great.
So globally, is this a ubiquitous organism that's found globally, or is it just found in certain parts of the world?
Absolutely a global organism. It is causes. We're in the seventh pandemic. I think everybody knows what a pandemic now is because of COVID, but it's a global pandemic, and we're in the seventh one now. Why they numbered them? That's something more for the epidemiologist, of which I am not one. But we are continuing to see outbreaks. World Health Organization, Robert, has really been interested in trying to reduce the number of outbreaks of cholera globally. And you do this through something with improvements in the main thing is improvements in water supply. And it's interesting. I was visiting Cambodia, which has very little cholera, whereas cholera is fairly common in Southeast Asia. I met a gentleman who had dug 400 wells in villages as a way to try to limit the spread of cholera so that people would have clean water supplies. What happens is when you don't have a clean water supply, and we see it over and over again, where water gets contaminated with human feces anywhere in the globe, really, is you can have cholera outbreaks, and unfortunately, the number of cholera outbreaks, which the World Health Organization was trying to um, reduce, actually increased last year from I think it was from 20 to 29, and
Yeah.
huge ongoing outbreaks right now in Malawi as a place, and then secondary to the earthquake in Syria. There was already a cholera outbreak, but it actually the cases had declined. But with the earthquake there, that number of cases have increased. The thing that's interesting is, though, that Turkey, the area where the earthquake happened was along the Syrian-Turkey border. Doesn't seem to have been an outbreak in Turkey. Now,
Right.
I've been looking at data. I looked at the data yesterday about this, and something like 50,000 cases since the earthquake. It was in February, I think.
Yes.
Is that right?
Yeah.
February in Syria, which was very disturbing information for me. And part of that is, again, destruction of the infrastructure, so you don't have good management of human waste, and it contaminates the water supply, and people drink that contaminated water.
Yeah.
So,
Okay, so since you said you're not an epidemiologist, we know you are a microbiologist,
yeah, I am a microbiologist, that I
right?
will admit to.
So I'm going to have you put your microbiologist hat on. And one of the more interesting things about cholera itself is the very rapid uh, pathology that can occur.
Right.
Can you talk about how this happens and
Mhm.
the
Well,
outcome?
Well, I think there's a couple things we need to talk about. One of the things that's really important is what sets a person up to get cholera. So we should talk about that. Um, where cholera is most problematic is in young children, especially if they're malnourished. Um, and think about a refugee camp, for example. Think about a rural area in Africa. Think about a place like City de Soleil, a slum, I guess is the best way of describing it. There's probably a cleaner way to uh, say that, where kids are malnourished. And so malnourishment, why that is important is the way you get cholera is you drink or eat food, drink water and eat food that's contaminated with cholera. The infective dose of cholera is very, very high. It's in the millions. So you have to ingest a million organisms
Mhm.
in order to get, or millions of organisms in order to get infected with the organism. However, if you are malnourished, you tend to have your stomach, you don't tend to produce as much stomach acid. You don't have as good innate immunity. And so the amount of organisms you have to ingest is lower. So that makes you more vulnerable. Okay, so the organism now has, you've drank the organism, you're malnourished, you're not, your stomach acid really doesn't protect you from this organism. And someone like Robert and me, we're well nourished, and
Too well.
uh, well,
I'm
uh,
speaking for
I
myself.
may also say I am too.
Okay.
So we have a high degree of stomach acid as well, and our innate immunity is good. So we're going to be less vulnerable to that disease than a young child who's malnourished and living in extreme poverty, who are more likely to be exposed to the organisms that and the organism that causes this disease, cholera, and in high numbers of organisms. When that organism is ingested, the organism attaches to small intestine, and the organism produces a toxin. And the toxin is very cleverly called cholera toxin, so there won't be any confusion. The toxin has two parts. It has an A part and a B part, and it's easy to understand why it's called A and B. Is the B part of the toxin binds to the enterocyte, the cell in the intestine, and the A site, which enters the cell, um, causes a biochemical reaction where the toxin stimulates adenylate cyclase, a specific enzyme in enterocytes, and then that stimulates a protein called protein kinase A, and that's all very nice. No, that's a lot of biochemistry, and
Mhm.
that might not be so interesting. But what the end result is that these people, they actually secrete chloride, and when you secrete chloride ions, water goes with it. And so these folks have a profound watery diarrhea. And they can actually excrete liters of fluids in a day. Now, if you have someone like me who's got a pretty good amount of body fluid, because I'm big, that you might be able to survive that. But if you're a young child who gets profoundly dehydrated, this can cause a hyponatremia, and then can lead to cardiac arrest and death. And so in the very young child who's malnourished, like we see in many of these outbreaks throughout the world, they're the ones who are most vulnerable. And they're the ones who are most likely to die from cholera. Um, the good thing about this, and then Robert, if you want to go on, is to talk about the treatment. Would you
Yeah.
like,
Let,
or
let
do
me
you,
just
do you
let me
want any
just let me
clarification?
Dr. Gilligan, let me just follow up on
Sure.
what you just spoke about. Of course, any of us that studied micro throughout the decades have heard the term rice water stool. Can you talk
Right.
about that
Sure.
as a symptom?
Essentially, yeah. So essentially, what happens is rice water stool is very simple. There's no inflammation in cholera. That's like so many diarrheal diseases. We see inflammation. You see white blood cells
Mhm.
and so on. So essentially, what when we talk about rice water stools, we're essentially talking about mucus and water. That's what a rice water stool is. And literally, it can be measured in liters from like an adult. I'm not sure what the blood volume is in a 20-pound child, the ones who are going to be most vulnerable.
Yeah.
But they can't lose anywhere near the type of level of fluids that we can.
So since this is a bacterium, antibiotics probably work.
No, that's not
No.
how you treat cholera. No, 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 no.
Okay.
I mean, no, it doesn't. It's very simple.
Hmm.
You replace the fluids that are
Hmm.
lost. Now, the trick is understanding the pathophysiology, and that's been very nicely worked out. We understand how to treat cholera very well. Um, in the industrialized world, no one dies of cholera. In fact, no one gets cholera, but that's because we learned very early on that if we have good
Sanitation.
waste disposal and clean water, nobody gets cholera. Um, and so let's use for an example when we had the outbreak, the hurricane in New Orleans. What was the name of that?
Katrina.
Hurricane Katrina. There was essentially the water systems were down. Um, we their sewage systems were down. Everything was down, but we had no one die of cholera. Where if in Haiti, where we don't have the kind of infrastructure and the medical care, we may see hundreds or thousands of deaths when there's an outbreak. Yemen is another example. Malawi, another example. We can go on and on and on.
Hmm.
Malawi is particularly problematic because we have a very simple treatment, and I'll get to that in a moment. This World Health Organization really feels that in an outbreak of cholera, the mortality should never be above 1%. Never be above 1%. Right now, Malawi, in areas of Malawi, that mortality is 4%. It's 4 times higher than expected. So that's really a human tragedy that's happening. So let's talk about the treatment. It's pretty simple. Essentially, it is sugar and salt water. It's a little more sophisticated than that,
Hmm.
but um, for those of you, Gatorade might be something you could use. Pedialytes, you may be familiar with Pedialyte. That would probably be the fluid that would be used a little bit more likely. You can actually buy, if you're a hiker, any kind of electrolyte solution that you have for hiking includes glucose. And the key thing here is that through some very sophisticated pathophysiological studies of cholera in animal models, they showed that you could reverse, well, you couldn't really reverse it, but you could increase fluid intake into these folks by using um, uh, glucose with salt solutions, essentially bicarbonate, sodium chloride, and potassium chloride, and could treat the disease. Now, the disease is fairly short. Usually 4 or 5 days, you're recovered. So the idea is you measure how much fluid goes out and you give that much fluid and you give it by mouth, and that's really important. Now the problem with it is, though, in adult you can do that, but in a child it really needs to be by IVs. And what's happening in places like Malawi, for example, they just don't have the places, and also Haiti, but for Haiti for different reasons, they just don't have the capability of giving IVs to young children who really, that's the best way they're going to get fluids. And there's certainly kids can, the older, child who can, you know, be fed by their mother, they certainly can be can get fluids that way. There's certainly that is something that can be done. It's really in the young child where who the diarrhea is so severe, they just can't ingest enough of this fluid. And that's why I think in part why the mortality has been so high in Malawi. And that seems to be in conversations with people who work in Malawi, that seems to be the problem. They just can't get access to the IV fluids that would be really important to them, or in oral therapies as well, in slightly older children, um, you know, a year old or something like that, where oral therapies can probably be used.
So, Dr. Gilligan, if the pathology has progressed to a certain point, though, is antibiotics ever an option?
Um, I'm not a fan. I
Mhm.
mean, certainly can read in textbooks that you use doxycycline or whatever, but
Right.
the pathophysiology is it's the uh, organism gets in the get adheres, the cells uh, are intoxicated. You get the diarrhea. Cells essentially die and get sloughed off. Goodbye, cells, good bacteria. They're pooped out with everything else. And so once those cells are regenerated, and again, that's a problem with malnourished children. They
Right.
don't regenerate these enterocytes. The disease is pretty much over. So antibiotics really, I think, are probably play a very minor role. Someone else who sees a lot of these patients may say, "Oh yeah, we use antibiotics all the time." I've not heard of that. I
Yeah.
think that when you read about from WHO and in Doctors Without Borders and other groups involved in the care of people, it's all about the oral
Food.
rehydration where it can be done, and if it can't be done, then IV hydration.
Well,
Rehydration.
antibiotics are used limitedly on most enteric type diseases because
Right,
they're self-limiting, right?
right, and cholera certainly is.
Yeah, yeah. Um, Before we start talking about some of the areas of the world, there's a vaccine. How
Yes.
effective is it?
Well, that's an interesting question, and I think that we don't. It's we. I'm hedging, as you can tell.
I see.
Um, yeah, I think that the data are that if you the idea is to protect people during the outbreaks. So it's different than most vaccines. We don't usually use them as a treatment, and it's not a treatment. What you try to do is surround the people who haven't been infected yet. You give them the vaccine with the idea that they'll be able to make antibodies, IgA antibodies, which would be best. It's an oral
Mhm.
vaccine. But if you use just one dose of it, the the data would say that it's very short lived, maybe 2 months at best. And what the World Health Organization says, you should give 2 doses of this oral vaccine. And then, you know, again, the data is not real firm because they're not doing clinical trials. They're doing observational research on this. But certainly 2 doses seem to be more effective than one. How long lasting, how durable that effect is, um, some I've read anywhere from 4 months to 2 years. So, but is there been a really way to say exactly how durable these vaccines? They're not. But the idea is to vaccinate people who have not yet been infected, hoping that would prevent the disease from occurring. And that's really how the vaccine's been using. Now, huge problem with the vaccine is there's not enough of it globally because we've had so many outbreaks. From what I can read, is that there is only one manufacturer right now in the world,
Mhm.
and they're limited in the number of doses that they can make, and they're just not meeting the needs. And so, back in I think it was October of last year, the World Health Organization went to did something they really didn't want to do, which was to say use only one dose of vaccine instead of two because they just didn't have the vaccine. And the outbreaks in Haiti, in Syria, and in Malawi, which are probably the major ones. Am I missing any that I can't think of right now, Robert? That you got?
Well, I mean, I know Lebanon had an outbreak
Yeah,
late
but their outbreak was very small.
right. But it was
It's
the first time in decades, though.
Yeah, absolutely, and
Yeah,
that came from Syria. So
yeah.
we know Syria, Yemen is another place. My understanding is the Yemen situation has calmed down.
The numbers
Uh,
are pretty small. Yeah,
yeah, they were
terrible.
horrible though. They were, horrible.
Correct.
A few years
Mostly
ago.
it's the African countries.
Right. So
Yeah,
Malawi seems to be, especially that 4% mortality is a really big problem. Really very disturbing. Syria, I think that they probably they're doing a better job. I guess the geographical area. Well, I don't know if the geographical area is smaller. And of course, Haiti has just been, they had a terrible outbreak, which probably peaked in December. There was like a little shoulder um, um, January, and now in the last couple weeks, they're down to about 50 to 75 cases a day from a peak of 4,500
right, right.
in December. So things seem to be calming down somewhat in Haiti, even though there's still tremendous disorder in Haiti, is my understanding. One of the things that it's interesting when you look at I've looked at CDC website before we came on yesterday. I looked at the Pan American Health Association website to see what's going on in Haiti, World Health Organization website, Doctors Without Borders, um, ProMed is another one for one. Where can you find these data? And I was really surprised. Very little. I think there was one article about ProMed Mail about what was going on in Syria, but outside of that, it's kind of hard to find data right now. I guess there was some data from Doctors Without Borders maybe about what was going on in Malawi, but it may have been in ProMed Mail. I don't quite remember where I saw that source.
Um, let's go ahead and take a look at your article and some of the things that you wrote.
Okay.
Let me put it up there. There it is. Cholera in Times of Chaos, and that's at asm.org. And I will link to that when I publish the podcast if you want to check it out. It's a good article.
Thank
And
you.
you write, cholera is a disease of poverty, natural disasters, and political violence. And that pretty much describes many of the countries we've talked about so far, right? A lot of these African countries, Haiti. Um, would you like to elaborate on that statement itself? Because it's absolutely true, but
Yeah. I,
but
I think that one of the, I think Haiti's a great object lesson in all of this. So we need to go back to the earthquake in 2010. Um, Haiti had not seen cholera for 100 years. So that put it in the same place as, say, the United States as far as cholera was concerned. We hadn't seen it in 100 years. Haiti hadn't seen it in 100
right,
years. But then something happened that started this unbelievable event. So there was this tremendous destruction. I can't remember the amount of destruction that occurred. There, you can read about it, I'm sure, if you wish to go back and read about it. But the World Health NGOs and aid organizations from all over the world came to Haiti to help the people. One of those groups was peacekeepers from Nepal.
mm-hmm.
Now, Nepal is a place where cholera is endemic. And when they sent the peacekeepers, they said they screened them for cholera, but cholera doesn't in fact cause clinical disease in everyone who is infected with it. You can be infected with a pathogen, a bacterial pathogen like cholera, and not have clinical disease, but you can excrete it in your stool. And so what happened is that they were in a compound in the northern part of the country, and they had latrines. The latrines were cleaned out by Haitians, locals And what they did was they took the stuff from the latrine and they dumped the stuff from the latrines in the Arbanet River. So the Arbanet River flows from, I guess, sort of the mountainous regions to the sea. But the people downstream, because there was such destruction in infrastructure, were using that stream for a source of drinking water. The feces from these soldiers contaminated the river. The organism grew in the water. Remember, it's aquatic bacteria. People drank the contaminated water, and there was an explosive outbreak that spread throughout the country of Haiti, and continued with hundreds of thousands of cases of cholera. Now, how do we know that really it came from the Nepal? Is this fake news? I mean, we live in a world where people are so skeptical about things, but there was some debate about, some very respected scientists said, oh no, this was water, naturally occurring environmental organisms. That was very well, cholera ecologist made that argument. However, when we looked at the genetic sequences of this bacterium, they were very similar to those that were found in Nepal, and not to anything that's found in the Western Hemisphere. So it was pretty good data, I think, that, and with the sort of shoe leather epidemiology that was done, the figuring out that the latrines were being dumped into the water, and that I don't know if they ever actually isolated organisms from any of the soldiers. I don't think they did. So that would be the smoking gun, I guess you would. But I think the data, most people in the cholera world would say that this was brought from Nepal by the Nepalese peacekeepers. There was nothing nefarious, or it was just an unfortunate occurrence, and that led to hundreds of thousands of cases. So then, the number of cases waxed and waned, finally decreased, and cholera, Haiti was called cholera-free. No more cholera in Haiti. And then,
and that was in 2019.
2019.
Yeah.
And so the last case was in 2019, but to be called cholera-free, you have to have 3 years. So I think in September of 2022, it was finally called cholera-free. And then in October, they started to see cases. And one of the things that I don't think was in the article, and we certainly don't really, it is mentioned, is that there is a political event that occurs in Haiti where the president is assassinated. Gangs take over a big part of the city, and there starts to be tremendous disruption. Probably disruption in the electrical supply, because we had inflation in fuel prices, and the gangs were blocking the fuel from coming in from the port, and so the water treatment plants didn't run, and so and the sewage treatment didn't work, and so all of a sudden we start to see an outbreak occur. And I think probably one of the seminal events in this outbreak, Robert, if I remember, actually was a prison outbreak, where
Yes.
a number of people became infected. And then the outbreak spreads to this Cité du Soleil, which is this inner city slum. And that's where most of the cases occur, although it has spread throughout the country, and also spread a small number of cases into the Dominican Republic. Hispaniola is an island where Haiti is to the western part of the island, and Dominican Republic is to the eastern part, and they're separated by mountains, but people move back and forth. And so there have been cases of cholera in the Dominican Republic, but a very small number. That probably, again, it's a wealthier country. They have good sewage, they have good water treatment, and so not really an outbreak. And that's important because for the Dominican Republic, a big part of their economy actually is tourism. So, outbreaks of cholera are not welcome because people won't go there if they think they're going to get sick. So we have a number of events that are, what do we got here?
I'm just throwing, this is the latest from the Haiti Ministry of Health.
Okay, the latest from, so one of the things I think that's interesting is that, and I think for our audience is to understand, is that these are estimates, and these are probably could be wildly inaccurate. I think that I gotta get my glasses off so I can read this, but the actual number of confirmed cases, I think, are 2,600.
Correct.
And the estimated is 40,000. So, and it's an estimated number. And one of the things that's problematic is these numbers could be, is probably, certainly the confirmed cases is an underestimation, because we know a lot of people are sick. What we don't know is that, is it 40,000 cases or 80,000 cases? We really don't know. The data is because the people who gather the data don't want to go into these areas because they're controlled by gangs. These gangs are very violent. They kidnap people. They have killed healthcare workers. People are afraid to go out at night, so they won't go to try to get healthcare. And Robert, you made the point early on, this is a disease that can kill in hours. So especially in a young child, the parents are afraid to go out on the street because of the violence that is there. The other thing that typically happens with cholera is that you try to have these rehydration stations where they use oral rehydration and primarily, but also intravenous hydration close to where the people are. The aid agencies have not been willing to do that because of the safety of their, because of concerns for safety for their employees. And so when there's chaos, as there is in Haiti, this is really contributes to the spread of this disease and to the treatment, and increases the mortality. Mortality in Haiti, I think, is estimated at 2%. But once again, how accurate those data, we just don't know. And so that's a real problem as well.
Yeah, and you could really say the same about, say, northeast Nigeria, where Boko Haram is. It's hard to get healthcare. It's dangerous up there, and
Right.
yeah, so you have cholera issues in that part of the country more
Right.
than other parts. Yeah.
Right.
Dr. Gilligan, I'd like for you to talk about look at your crystal ball. What do you see with the future of cholera compared to what we got now? And do we have a way to, get this under control? I mean,
Okay.
I know there's things out there, but
Okay.
the
So
whole
I mean,
package, there's so many problems. Yeah.
right. The issue is very simple.
Mm.
Globally, we have to have the will to do simple things, and that is better infrastructure, which means, the guy I met in Cambodia who's dug 400 wells. It doesn't require the World Health Organization. It doesn't require the government. It's just the people have to have the will. There's certain organizations that to me are amazing. Gavi's one of them, which is the Global Vaccine Initiative. Global, I can't remember the A.
Well, it's
Global
GAVI.
Alliance for Vaccine
Mhm.
Initiative. NGOs that are working in the field, trying to improve infrastructure globally. You know, cholera doesn't exist in the industrialized world. Let's just be honest about it. If you look at places like Singapore, you look at places like Japan, even in Cambodia, there's not any cholera, really. Um, it, um, but if you look at places where there is poverty, lack of infrastructure, malnutrition, um, that's where it's a real problem. And I think the other thing that we've not talked about, but I think global warming is something that is a real concern. The outbreak that's happening in Malawi, where 4% of people are dying, that's a lot of people to die from a disease that, essentially, if you could drink enough Gatorade, you'd survive. Think about that. I wouldn't drink Gatorade. There's other stuff I'd rather drink, but that's the idea. But what's happened there is because of global warming, the cyclones that they get every year have been much worse this year, and so the flooding has made it impossible. And flooding in rural areas has made it impossible for folks like Doctors Without Borders or the Catholic Relief Services to get there to provide the support they have. I think the other thing is that the vaccine probably is important in controlling outbreaks, and but we don't have enough vaccine because of the cases. I think the other thing that happens is there's going to be natural disasters. Natural disasters occur in areas where there's not civil order. Let's think about Syria right now. The outbreak that's occurring in Syria is in Aleppo, which is the rebel region. I don't like that word rebel, but that's what the news folks and and they just don't have the resources. They're trying not to get killed by during the battles that have been ongoing. So we really need to think about, we have this disease which um, people still die of, that we would never accept in this country. If there was an outbreak of cholera in this country, I think, I hope we would rally around it. Maybe COVID says that maybe we might not, but
Yeah,
I think
I think
that,
I think it'd be contained pretty quickly.
yeah, it would be contained. And remember Katrina, which was, you know, if you saw, the bathrooms didn't work in the Superdome, and there was water in the streets, which, could easily be contaminated with human feces. Yet there were two cases, and there were people who ate shrimp that was contaminated in the water, from the water. That was it, and I've looked at these data very, very carefully. And so, we have to understand what our responsibility is for folks in this world. We are in we live in a privileged world. We really do. And I think a lot of people, we have so many places where people are fighting with each other. I'm not going to wear a mask. I'm not going to do that. But do we appreciate that when we have a hurricane, we do not have outbreaks in cholera, but when they have a hurricane in Malawi or Bangladesh, or God forbid in Haiti, they have outbreaks of cholera because they do not have the infrastructure that in this country you and I have paid for. By the way, that's where our tax money goes to. One of the places it goes to, and we're fortunate. And I think the other thing is that their science has been powerful to show, there's a simple way to treat this, and that we don't need doctors. You can train. I could train Robert in an afternoon how to give oral rehydration therapy, or Robert could train me. It's either way you want to do it. And we could go in there and we could save lives. And that's what the people with Doctors Without Borders, what are they called? The White Crescents. The White Crescents are relief organization people in Syria, for example, the Red Crescent in Yemen, and on it goes. I think the other place that I'm watching very carefully right now, Robert, is the Sudan. What's going to happen there now that they have a civil war? And Again, there's going to be tremendous disorder. People are going to be living in refugee camps. It's interesting. I just will digress just a second, if I may. I'm working with a young woman who wants to go to medical school. She is a refugee who lived in a refugee camp, and they had a cholera outbreak in her refugee camp. And she writes in her personal statement for medical school that she felt guilty about throwing water balloons. That she lives in the United States. Well, I won't say where, but throwing water balloons, because she remembers when she had to wait in line in the morning for hours to get clean water out of the one well that was in the refugee camp. So we are so privileged, and give $5 to Doctors Without Borders. Give $5 to whatever charity that contributes to global health, if you can. I think that's the way we're going to deal with this problem. We hope there's better vaccines. Cheaper vaccines are really important. That's another approach. But the bottom line, it's clean water and sanitation is how we control cholera in this country, how it's been controlled in the industrialized world, and how it can be controlled in the middle and lower income parts of the world.
Dr. Gilligan, let me ask you one more thing. I know it's dinner time for both of us.
And my wife, I cook dinner at our house, so I got to get doing it.
One quickie.
Okay.
You talked about only one manufacturer of the cholera vaccine. Your thoughts on that? Because clearly there's a market for it.
But is there profit for it? That's really the issue. And again, I'm not quite sure why the manufacturer discontinued. There were two, and one of them discontinued it. We make a vaccine in this country, but it's very expensive, and we give it to travelers who can pay. I forget what the dose cost. It's expensive. I think and I don't know, it's like 15 or 20 or maybe 50 times more expensive than the doses by the World Health Organization. That's really the issue. We have to have the scientists have to come up with improving the technology so that it can be made as inexpensively as possible, so that we can provide the millions of doses. I mean, we're talking in Haiti, 1.2 million doses of, I believe it was, that they did. I think they just sent a similar amount to Syria, but I think that the manufacturing capacity is not a lot more than a couple million doses a month. So, and there's no stockpile. The stockpile's gone. That's why they don't do the 2 doses. And so that's really, a huge issue right now.
All right. I really appreciate this time you spent with us, Dr. Gilligan. And again, for the audience, if you want to check out his article, it's Cholera in Times of Chaos, asm.org. I'll link to it in the show notes. And I want to thank you, Dr. Peter Gilligan, for this very informative talk. I appreciate it.
Thank you, Robert. And thanks for picking me up when I couldn't quite remember everything.
You bet.
Appreciate that.
All right. Hope to talk again soon.
Thanks. Okay. Take care. Thanks. Bye-bye.